Aplikasi Dokter to Dokter bisa di-download di Play Store maupun App Store secara gratis. Kemudian install aplikasinya. Registrasi cepat bisa dilakukan melalui akun Facebook dan Google Mail. Untuk yang tidak memiliki Facebook dan Google Mail, registrasi bisa dilakukan dengan menekan tombol register. Isi nama, email, dan password Anda. Verifikasi email Anda dan masuk kembali ke aplikasi. Tunggu apa lagi? Download sekarang dan dapatkan beragam manfaatnya.
Hadirin sekalian, jadi pada 3 sesi ini tidak ada tanya jawab, tidak ada rangkuman dan kesimpulan. Dan kita menginjak pada sesi yang kedua, ini adalah video session dari Michael Ruma dari New Mexico. Beliau mengenai history dan anamnesa dan pemeriksaan ultrasound dan intervensi sedikit untuk mencegah prematuritas. Silakan video sessionnya.
Thank you very much for taking the time to join me today. I'm here to talk about history, ultrasound, and protocols, how we can prevent prematurity. A few quick disclosures. I work as a maternal fetal medicine physician in New Mexico. I also do some consulting work for Hologic, CCSI, and Philips Ultrasound. If you ever have a chance to come and visit me in New Mexico, I'd really encourage you to come visit us in October when we have the world's largest international balloon festival. Each morning for 2 weeks, 600 to 800 balloons take off in a mass ascension over the Rio Grande River, and it's just an absolutely spectacular sight to behold. And I'd invite you to come visit me someday in the future. I'd like to take this time to just go over what we're going to discuss today. We're going to review issues surrounding preterm birth. We're going to discuss ways to approach pregnant patients in order to prevent preterm delivery using history, ultrasound, and specific protocols. And I think it's really important to look at the landmark literature that create our current standard of care. Roberto Romero is one of our most famous maternal fetal medicine specialists in the United States, and he says that preterm delivery has been and remains the most important challenge to modern day obstetrics. And in the UK, Stuart Campbell says basically the same, that preterm delivery with its collateral effects on neonatal mortality, short and long-term infant morbidity, and astronomical healthcare costs is the foremost problem in modern day obstetrics. Just a little bit of statistics on preterm birth. So preterm birth is delivery prior to 37 weeks. You know, it's the leading cause of infant morbidity and mortality worldwide. And if you're unfortunate enough to have a preterm birth at 24 weeks, you can see that the rate of death is over 50%. This number goes down as we get preterm deliveries closer to 28 weeks. And if we make it to 32 and 34 weeks, there are very, very few complications. Unfortunately, preterm deliveries don't just face a mortality rate, they also face complications including respiratory distress syndrome, intraventricular hemorrhage, and long-term complications including neurodevelopmental disorders, deafness, blindness. Most of preterm deliveries are spontaneous. 70% of all preterm births are due to random Mother Nature's effect on the pregnancy. Over almost half of them are related to preterm labor. A quarter of them are related to preterm premature rupture of membranes. And 30% of preterm births are due to what you in the audience do to your patients. We have to deliver patients and we have to perform medically indicated deliveries for preeclampsia, for growth restriction in the setting of non-reassuring fetal heart tones. And ultimately, we're responsible for some of those preterm births as well. In 2010, there were almost 15 million babies born preterm worldwide. 1 in 10 infants is born premature throughout the globe. As you can see, Asia makes up a huge percentage of the global preterm births. Over 50% emanate where you're sitting at today. And these deliveries occur really throughout all of Asia, with India having the highest proportion of global preterm births. But Indonesia is not far behind, ranking number 5 in global statistics. But my country, the United States, also ranks extremely high in these preterm birth statistics as well. And so we all have a lot of work to do in this realm. In the United States, we have about 4 million births annually each year. And each year, we have almost 10% of those births born preterm. The March of Dimes is an organization that grades how we're doing in management of preterm deliveries. And you can see that we're not doing great, receiving a report card of a C with a 9.9% preterm birth rate. Unfortunately, you can see that our rates had been going down since 2007, but as we hit 2015, 16, 17, 18, and beyond, those rates are going up. This is a map of the United States just to give you an idea of who's doing well and who's not doing well. I told you I live in the state of New Mexico, and we're actually not doing well. We have a C, 10.3% preterm birth rate. These preterm birth rates cost us a lot of money. Short-term hospitalizations, almost $5 billion spent. And annually, we spend about $26 billion. And I'd ask you to look at the reference. This was from 2011, which basically says that we're not doing a great job, and these costs are likely much higher in today's dollars. But you know, that's only part of the story. The less appreciated burden of preterm birth is borne by the families caring for preterm babies. We've investigated a ton of different strategies to identify patients and try to treat them, but not many of those have done well. So let's discuss how we might use history taking in the office, ultrasound, as I know, as maternal fetal medicine specialists here in the audience, we all love to do ultrasound. And then how can we follow specific protocols? How can we prevent prematurity using protocols? Let's talk a little bit about patients with a history of spontaneous preterm birth first. So one of the strongest risk factors for preterm delivery is having had a prior spontaneous preterm birth. We know that after at least one, your risk is at least twice as high based on background risk. And this is just data showing recurrence risk of delivery in a variety of studies, both in the United States and around the world, showing recurrence rates of at least 2, upwards of 10-fold times higher if you've had a prior spontaneous preterm birth. If you're a patient who's had 1 prior spontaneous preterm birth, the risk of recurrence is at least 15%. You have 2 of them, 40% in the 3rd pregnancy. And if you've suffered 3 preterm spontaneous preterm births, your 4th pregnancy has a 67% chance of delivering preterm. And this is just a graph from Kathy Spong showing how if we have term deliveries, we do much better than the patient who's had recurrent spontaneous preterm births. A lot of data to date, really emanating from the 60s and in the numerous decades beyond, recent data continues to place a significant impact on how progesterone can help women who've had a prior spontaneous preterm birth, as well as those who we as MFM doctors identify with the short cervix on ultrasound. Progestone. Pro in favor of gestation, and own the chemical structure of this hormone. It's intended to remind us of its crucial role in pregnancy. One of the first and foremost articles in medicine in the United States was this article from the New England Journal of Medicine, Prevention of Recurrent Preterm Delivery by 17-alpha-hydroxycaparate progesterone. Published in 2003, they enrolled women with a history of spontaneous preterm birth from 16 to 36 weeks, gave them weekly injections of 17P. What did it do? Well, it showed a significant reduction in spontaneous preterm birth, a 33% reduction in the rate of preterm birth less than 37 weeks, and a huge reduction, 42%, in extremely preterm recurrent deliveries that were early. It's one of the first times that we identified with a randomized controlled trial in multiple different subsets, different ethnic groups, and throughout gestation at 37, 35, and 32, significant benefit to birth. And you can see these statistics shown in this table here. We continue to see improvements across gestational age using injectable progesterone. which is what we do as the standard of care in the United States today. And we know there's no long-term adverse effects to this medication, as we followed it up in multiple studies, in this one, particularly by Northern. What else can we do to these patients? We know that 17P isn't the only thing that's helpful for that patient who's had a prior spontaneous preterm birth. In this randomized controlled trial by Owen, women with that history who were on 17P were followed, and if they had a cervical length less than 25 millimeters, they got a cerclage. And what did that demonstrate? So ultimately, for delivery less than 35 weeks, if they have a cervical length less than 25 millimeters, and this is followed every other week from 16, 18, 20, 22 to 24 weeks, it showed a not statistical, but very close reduction in spontaneous preterm birth, less than 35 weeks. And this is the Kaplan-Meier curve showing that. But a secondary analysis showed that in the 15 to 24 millimeter stratum, there was indeed a benefit for those patients of 0.23, or a huge reduction in recurrent preterm birth. And here's the Kaplan-Meier curve showing those women who did not receive a cerclage and those that did, and the ones receiving a cerclage staying pregnant much longer, particularly under 15 millimeters. So what does the American College of OBGYN say about all this? They say that a woman with a singleton pregnancy who's had a prior singleton spontaneous preterm birth should be offered progesterone supplementation starting at 16 to 24 weeks in order to reduce her risk of recurrent spontaneous preterm birth. And they say that there's insufficient evidence at this time to say whether or not cerclage together has an additive effect, but I will say that most experts in the United States still follow this strategy, particularly because of the secondary analysis under 15 millimeters showing a definite benefit. What does the Society of Maternal-Fetal Medicine say in the United States? Again, 17P in a dose of 250 milligrams intramuscularly on a weekly basis starting at 16 to 20 weeks. It has better effect if it is started earlier in pregnancy. So we do our best to get these patients dated, identified early, and started immediately at 16 weeks. And that if the cervical length shortens to less than 25 millimeters prior to 24 weeks, that cervical cerclage should be offered to the patient. Despite all this evidence, though, 17P in the United States is still underutilized, and we know that by looking at insurance plans. In the state of Louisiana, Medicaid reimburses for 17P, but they found that only 10% of pregnant women that were considered at risk of preterm delivery actually received this very beneficial medication. Incredibly important that we pay attention to these patients and identify them using their history and getting them the medication that they need. What about patients without a history of spontaneous preterm birth? Because that really is the majority of patients that have the actual true experience of delivering preterm. So perhaps the most interesting issue today, this is again in 2007, if we go back a little over a decade, perhaps the most interesting issue today is whether the low-risk woman with singleton gestation and no prior history of preterm birth should every one of those patients undergo a vaginal ultrasound to assess their cervical length? Why is this so important? Why should we be looking with a vaginal ultrasound in the mid-trimester at all pregnant women? The reason is that only 10% of patients with spontaneous early preterm births are occurring in the patient who's had a prior spontaneous preterm birth. We know 17P injections are the current standard of care for these patients, but if we don't have another strategy, we're missing 90% of patients that could benefit from something else, and ultimately our strategy is flawed if we're only trying to identify people based on history. So in 2007, Eduardo Fonseca showed us that progesterone and the risk of preterm birth among women in short cervix is critically important to look at. He did a randomized controlled trial looking at singletons and twins. And if the cervical length between 20 and 25 weeks was less than 15 millimeters, those individuals were randomized to vaginal progesterone. And they used a compound called Utrogestan. which is available across the globe. It's not available in the United States, but there are other compounds like permetrium, which we utilize for this purpose. This was a really big study. They looked at 24,000 women. About 2% of women had a short cervix at this definition of under 15 millimeters. Did it benefit the women if people with a short cervix got nightly utrogesterone, nightly vaginal progesterone? Look at this reduction, 44% reduction in spontaneous preterm birth if you, in the audience, identify 18 to 24-week patients with a vaginal ultrasound, and if the cervix is short and abnormal, put them on vaginal progesterone. We did this study in the United States as well in 2011. Sonia Hassan completed this study. Vaginal progesterone reduces the rate of preterm birth in women with a sonographic short cervix. Primarily in the United States, they did enroll a few patients outside of the United States, all singletons, ultrasound from 19 to 24 weeks. And they enrolled patients if they had a cervical length between 10 to 20 millimeters. And they gave them a medication called Crenone, which comes in 90 milligram vaginal progesterone gel, and it's a bioadhesive micronized progesterone. They looked at a lot of pregnant women, 32,000 pregnant women, but again, about the exact same as Dr. Fonseca, 2% of women have a short cervix. They randomized those patients to vaginal progesterone versus placebo. And again, look at the outcome, identical to that of Dr. Fonseca, a 50% reduction in spontaneous preterm birth in the group that got vaginal progesterone. This study was unique because it showed that the outcome did not simply reduce preterm birth, but it also had benefits for the infant. It reduced respiratory distress, and it also reduced composite outcome scores of adverse neonatal outcomes and reduced the risk of having a low birth weight infant. This is the first study to demonstrate that vaginal progesterone actually had a benefit, not only on improving the gestational age at which preterm delivery occurred, but also improving the outcome for the infant. The takeaway of this study is that the administration of vaginal progesterone gel in women that have a short cervix does reduce the frequency of preterm birth, and it also improves neonatal outcome. This study's been replicated. There's at least 5 trials to date about this. Almost 1,000 women have been treated with vaginal progesterone, and you can see that the relative risks all show significantly beneficial circumstances for the patient as well as for her infant. This is the meta-analysis showing that we should be using vaginal progesterone for these patients. Is it cost effective? Can we do an ultrasound on all pregnant women in the United States? Could you in Indonesia do an ultrasound on all of these patients throughout your country? Could you give them vaginal progesterone? We estimated from a study by Cahill that this would save us $13 billion. I showed you that it cost us $26 billion in the United States to take care of infants born preterm, a massive savings if we're able to implement this strategy. What does the American College of OBGYN say? It says that vaginal progesterone is indeed recommended as a management option to reduce the risk of preterm birth in asymptomatic women with a singleton gestation who do not have a history of preterm birth that are identified with a short cervix. And what does my society, the Society for Maternal Fetal Medicine, say in the United States? Again, similarly, it says in those patients with a short cervix, either 90 milligram gel or 200 milligrams suppositories can be utilized to reduce the harm of preterm birth in those patients that have a short cervix. Why is this so important? We need to do this ultrasound vaginally. If you take a look at this picture, how long would you look at this patient? Would you look at her for a few seconds? Would you look at her for a few minutes? Super important to know what you're doing when you're doing a transvaginal ultrasound. Here's minute 1, minute 2, minute 3. It's quite a different cervical picture, correct? You can see that this patient previously looked like she had a normal cervix, but in waiting a short period of time, you can see that her cervical length is only 5 millimeters, and she has a U-shaped funnel presenting. Knowing how to do a transvaginal ultrasound is critically important if we're going to implement this kind of evaluation across a country in your own clinics. We need to be trained on how to do this. It is time for all of us around the globe to do universal transvaginal cervical length screening, and I would encourage you deeply to consider doing this in your practices within your country. Future studies will define the optimal cervical lengths, whether or not we should do this with twins, but ultimately this should not delay the implementation of a program based on the paper of Hassan. Our patients and their babies deserve no less, according to Dr. Stuart Campbell. If you want to know how to learn and evaluate that transvaginal cervical length, I really encourage you to check out this organization called Cervical Length Education and Review, which is part of the Society for Maternal Fetal Medicine and its organization called Perinatal Quality Foundation. There are several lectures available at this website you can see here below, and this will teach you how and demonstrate your education and knowledge about how to measure a transvaginal ultrasound appropriately and do it well for your patients. This is the current paradigm we have in the United States, and this is an algorithm starting with singletons, going to those that have had a prior preterm birth. You can see that they get 17P, and they get evaluations by ultrasound, and then they get a cerclage if they have a short cervix. But for those asymptomatic patients, those individuals should get an ultrasound between 18 and 24 weeks. If they have a short cervix, they should be placed on vaginal progesterone. What else can we do? So we talked about patients with a history of spontaneous preterm birth. They should get 17P evaluated by vaginal ultrasound and cerclage if they have a short cervix. What about those patients that without history of spontaneous preterm birth? Well, I told you we should be doing universal transvaginal cervical length screening and putting them on vaginal progesterone. How about improving spontaneous preterm birth for any patient? And could we as physicians, could we as midwives, could we as providers for pregnant women that are interacting with pregnant women all throughout the globe, could we prevent medically indicated preterm birth as well? Let's talk about how we can improve preterm birth rates for every pregnant woman. Inter-pregnancy intervals. We all deliver babies. We all see them after for their postpartum visits, but do we talk to them about whether or not they should achieve another pregnancy and when should they be trying to achieve that next pregnancy? So the interpregnancy interval is defined as the time interval between one pregnancy and the next, and it affects the risk of pregnancy complications, one in particular, preterm birth. And we know that if we get pregnant too soon, a short interpregnancy interval, or we get pregnant too late, a long interpregnancy interval, both of those are associated with adverse outcomes. But the majority has been associated with short interpregnancy intervals. This is a graph demonstrating that there's a significant issue if you get pregnant under 18 months from your last baby. So we need to tell patients to wait at least a year and a half before they attempt a subsequent pregnancy. They need to think about family planning, use methods that are available to them to avoid pregnancy at least for a year and a half after they had that last child. And we also should encourage them that that interval should not last longer than up to 5 years. So a year and a half to 5 years is the sweet spot for trying to have a subsequent child in order to decrease your risk of complications, one being very significantly spontaneous preterm birth. The optimal interval between delivery and your next pregnancy is 1.5 years to 5 years. And the greatest risk of low birth weight and preterm birth occurs when that interconception, that short IPI interval, is less than 6 months. We have to avoid rapid pregnancy successions, and we all can do this by counseling and talking to patients. The March of Dimes in the United States provides some information that's freely available. I'd really encourage you to provide this kind of information for your patients to try to message to them, avoid getting pregnant quickly. We want to wait at least 18 months before we get pregnant again. How do we prevent medically indicated preterm births? You know, those ones that we're responsible for as doctors, preeclampsia, growth restriction, etc., where maybe we have to deliver the patient. Preeclampsia and preterm birth affects about 4% of all pregnancies, and 15% of preterm births are attributed to this single diagnosis of preeclampsia. It's a huge cause of medically indicated preterm birth. Are you giving your patients, are you recommending that patients utilize aspirin to reduce the risk of preeclampsia? We know that aspirin helps, and we've looked at this with a very large study performed in 2017, published in the New England Journal of Medicine. This was a randomized controlled trial. Women at risk for preterm preeclampsia, and we'll review that, were given either placebo or aspirin 150 milligrams daily from 11 to 36 weeks of pregnancy. Now, what did that very simple intervention of taking a daily low-dose aspirin actually do? It reduced the risk of preeclampsia from 4% to almost less than 1.5%, an odds ratio of 0.38. 1 minus 0.38 is a 62% reduction in preterm preeclampsia simply by asking your patient to take a daily low-dose aspirin. Here are the U.S. recommendations for aspirin during pregnancy. These come from the U.S. Preventative Services Task Force. And they want us to look at asymptomatic pregnant women and what are their risk factors for preeclampsia. Do they or have they ever had preeclampsia in the past? Are they a multifetal gestation, twins, triplets, etc.? Do they have pre-existing hypertension? Do they have diabetes of any sort, type 1 or type 2, entering the pregnancy? Do they have underlying renal disease? Or do they have autoimmune conditions like lupus or APL syndrome? In the United States, they recommend, the federal government's making this recommendation to us as doctors and providers, that we should be identifying these patients, placing them on low-dose aspirin, 60 to 150 milligrams, starting at around 12 weeks. And it can be started as late as 28 weeks because there is a significant reduction that we just saw in that New England Journal of Medicine article. If patients in the United States have these high risk factors, these patients for sure are recommended to start low-dose aspirin. If they have moderate risk factors, such as being a first-time pregnant woman, are overweight or obese with a BMI over 30, if mom has a family history of preeclampsia in her mother or her sister, if she is African American of low socioeconomic status, if she's an advanced maternal age pregnant patient, or if she has other risk factors, like maybe she delivered a low birth weight infant, or maybe that she's waited 10 plus years to try to have a second pregnancy, that short and long interpregnancy intervals that we're supposed to be paying attention to. If you have several, which I would say is at least 2 of these risk factors, these patients should be definitely offered low-dose aspirin as a risk reducer for having preeclampsia in their pregnancies. Now, I would ask you all, this is not difficult to do, discuss with your patients, ask them these questions, identify these folks, and get them to take a low-dose aspirin. The American College of Obstetricians and Gynecologists supports this recommendation and agrees with the USPSTF in the United States, and for incredible reasons, very, very easily to reduce that risk of preeclampsia by taking something that's simple and over-the-counter and incredibly inexpensive, that low-dose aspirin. We've talked about a number of different topics today. We've talked about history and how we can prevent that individual who has a history of spontaneous preterm birth using 17P, vaginal ultrasound, and cerclage to help that individual not have a recurrent spontaneous preterm birth. We've talked about ultrasound. We're all maternal fetal medicine specialists here. We love using ultrasound. Don't use it just to measure the pregnancy. Don't use it just to measure the amniotic fluid. Measure that cervical length, and ideally that should be done using a transvaginal ultrasound because it gives us the absolute best images and the most accurate measurement of that cervix. We should be doing universal transvaginal cervical screening on all asymptomatic pregnant women at 18 to 24 weeks at least one time to identify those candidates that have a short cervix and put them on this ever important compound of vaginal progesterone. And we know that we can also improve spontaneous preterm birth for all patients just by counseling them, talking to them, helping them avoid that short interpregnancy interval. It's incredibly important. And we also know that we can prevent what we don't want to do, that medically indicated preterm birth for preeclampsia. We can help tremendously by identifying and advising those individuals who've had prior preeclampsia, who have diabetes, who maybe have multiple risk factors for preeclampsia, like we've discussed earlier. We need to simply identify those folks and put them on a low-dose aspirin. I really appreciate your attention today. I look forward to visiting with you, and I want to encourage you to pay attention to November 17th this coming year, because it's World Prematurity Day. Make a point to try to prevent spontaneous preterm birth using the variety of mechanisms that we talked about today. Thank you very much, and I will see you the next time.